We have a crisis, obviously, we know that. And let me tell you a little thing about the ER. We have a crisis going on right now. Who had the flu this year? Okay, so I don't know if any of you had the opportunity to go to an ER. It's absolutely insane right now in the ER. So at our ER, we have 190 a day. Well, during this flu crisis, it's 270. So you have to think outside the box, right? You have to think, what are we going to do about this? Just store everybody in the waiting room? Well, of course not. We're going to have to increase our services. We're going to have to give more access to our patients that are coming, right? So we have to think outside the box like Mr. Fontaine's talking about. We're about to publish a paper, actually, American College of Emergency Physicians. I'm a co-author in it, and we're trying to educate ER physicians on how to start using medication in the ER. So these are things that we are trying to get out there, get people knowledge, get people the education they need so they know how to treat patients adequately. All right, let's see if this thing works. Some of the objectives, we're going to discuss the current opioid epidemic. I know you know about it, so we'll go through that pretty quickly and understand how opiates change the way the brain functions, and then understand the role and function of various medications in substance use disorder. So the opioid epidemic, you know, as a doctor, we write prescriptions, and we kind of noticed a trend. We started writing a lot more prescriptions. There was this thought that maybe if we were giving a whole bunch of OxyContin out, it's not addictive, that would give good pain control, and lo and behold, guess what? It was wrong. It does cause addiction as well, and so we had to rethink that. But as you can see, the opioid prescriptions since 1999 had quadrupled, pretty high. You can see the states that are in purple are about 3 times higher than other states. So there's focus in certain areas, maybe the Ohio River Valley area, but Florida's not out of that loop either. As you can see with the prescription pain, the more prescriptions you're writing, the higher the death rate happens from those prescription opioids. That kind of makes sense, right? Here's a disturbing slide from Nora Volkow at NIDA. Of the doctors that are writing prescriptions, of their patients that actually had overdose from their narcotic, right? 91% were still writing for that prescription for the opiate still. That's insane. So is this a breakdown in communication? Did the doctor not know that the patient went to the ER with an overdose? Who knows? 17% of those on high-dose patients overdosed again within 2 years. So that's a major problem. Obviously, we have to have the education to the doctors understanding, hey, this is a problem, they can overdose, what are we going to do about that? And when they do overdose, what are you going to change? The medications are changing a little bit. As you can see on this slide here, well, first of all, in 2016, 64,000 people died of a drug overdose. Worst ever year in history that people died of an overdose. 2/3 of that are from opiates. Actually, the highest is not prescription medications. The highest are now, well, if you combine heroin and then also you talk about some of the synthetics, carfentanil, fentanyl, that type of stuff, are escalating gigantically. Why is that? They're cheap to make, right? They're cheap to make, they're very strong. Fentanyl, 100 times stronger than morphine. Carfentanil, 100 times stronger than fentanyl. That's 10,000 times stronger than morphine. So if you're a dealer, right, and you can make this pretty cheap, you're like, hey, I'll just use a little bit of this stuff, right, just a little bit. Well, what's a little bit? I mean, if you're talking 10,000 times stronger than morphine, we're talking micrograms, right? So if you put a little bit more than a few micrograms in there, you're going to potentially have an overdose situation for your client that is buying your drug. The death rate as we started kind of getting control of our pill mills, right? The prescriptions start to taper off a little bit. Great. We're going to fix addiction, right? People aren't going to be addicted anymore. This is fantastic. But wait, on the right, you can see that heroin starts to go up. So there's going to be another source out there, right? This is not going to go away. So we can try to stop all that from happening, but there's going to be other sources of the drug that come out. We're not out of it in Florida. These are Florida statistics here. And as you can see, as the prescription medications start to taper off, you can see methadone actually is going down as well for overdose. But you start seeing that the non-pharmaceutical type of fentanyl, carfentanil, those medications are starting to go up as well as heroin. And here's another situation where you can see heroin's escalating upwards, but even the synthetics, the fentanyl, are going much higher than the heroin because it is so cheap and it is so strong, and so it's easy to get access to that as well. We have an epidemic of deaths. Like I said, 64,000 people died. That's 146 deaths a day in 2016. 146. I gave this lecture, 2014 numbers, 92 deaths a day. 2017, it's even going to be higher. We don't have the stats yet, but it's going to be higher. 14 people die a day in Florida from overdoses. For every overdose, there's about 27 to 30 patients that show up to the ER with non-fatal overdoses. So it's a tremendous amount above and beyond what we see just from the overdose deaths. What's the medical cost? $442 billion. $500 billion is the medical cost. Not just the medical cost, but we're talking about lost productivity at work, healthcare fees, criminal justice system. If you think about it, it's only 5% of the cost actually goes to related to treatment. 5%, that's pretty low. And obviously what we just saw in the last speaker, MAT has proven to significantly reduce these costs as well. So let's talk about addiction. So we have thought about addiction. I don't know if you've been in this a long period of time, but it's a behavioral issue, right? That's how we've always kind of looked at it. This is bad behavior, so we should punish the behavior. But we started realizing maybe we were wrong, all right? Maybe it's not just a behavioral problem. Maybe it's something else like a disease, like we treat in medicine other diseases as well. And so after years, we've started to realize this is a disease of the brain. It's a disease of brain reward, motivation, memory and related circuitry. There's a dysfunction in that circuitry over a period of time where individuals start to pathologically pursue the drug and other behaviors that they wouldn't have pursued before. We also notice, like a disease, there's cycles of relapse and then remission as well. And then if you don't get treatment to these folks, then there's a higher chance of disability and even death. So addiction is a disease of both the brain and behavior. And just like other medical disorders, it can be treated effectively with medication, right? So we think of treating diabetes and asthma and hypertension. We don't just say, well, here's a medication and go about your business. No, there's a behavioral change and there's medication, right? So if you're a diabetic and I say, hey, listen, stop eating donuts and your diabetes should go away. Does that work? No, not always. Could it work? Yeah, maybe with some people you could abstain from all these bad habits and the things you eat, and maybe you won't have to be on medication, but the vast majority are going to have to be on medication, right? So why don't we say, let's just give them medication? Do I tell a patient, hey, you have diabetes, here's some insulin, and now you can eat whatever you want. Go get a box of donuts, have fun. No, that doesn't work either. So we have to approach it from both ends, right? We have to change the behavior, and we can use medication at the same time in conjunction together. There's genetics, environmental factors that play a role. And like other chronic diseases, there's no reliable cure. And I think that's where a lot of us get kind of hung up. There's got to be a cure. When you think of chronic diseases, we talk about managing chronic diseases, right? Not necessarily curing chronic diseases. That would be great if we could do that, but most of the time we need to think about it as management. The longer a patient adheres to that treatment plan or that management, the better are the results. How are addictions like other medical disorders also? Well, the better the patient's personal stability, family support, employment, the better the outcome. Same with other chronic diseases, right? You give support to people that have hypertension and diabetes, they have better family support, they can make their doctor's appointment, they have structure in their life, the better their outcomes as well. It's predictable. 80% of patients that leave medication-assisted treatment under 1 year relapse. So it needs to be treated like a chronic disease, not just an acute disease, right? So we don't treat it just like strep throat. Here's your antibiotics and have a great day and you're good. We have to think of it more like a chronic disease like hypertension and diabetes and asthma. And managing these diseases help with the other bad things that happen with it, right? So diabetes, if you're out of control with diabetes, you have an increased chance of heart disease, peripheral vascular disease, renal failure. So the better we have control of their diabetes, the less chance they're going to have these bad sequelae. Same with medication-assisted treatment. Less HIV, less hepatitis, less activity that's causing problems in their lives as well. So why do people get addicted? A lot of different reasons. People do it, this may be a little voluntary at first, right? They say, hey, I want to use some drugs, I want to start to feel good, or maybe I'm anxious, maybe I'm stressed out, maybe I need something to help me get past that a little bit. Maybe it's because I'm being I want a little edge. I want to be on top of my game. I want to be above this so I can have a certain ability to be on to other people or whatever. Maybe it's just peer pressure. Everybody else is doing it. I'm kind of going along with the crowd. We see that in our adolescent group quite a bit. So initially, this may be a voluntary decision, right? But continued use, most people think, hey, I got this under control. But in continued use, they start to lose that self-control. They start seeing physical changes, literally physical changes in the brain that start affecting their judgment, their decision making, their learning and memory, and behavioral control. So at first, those positive feelings, person feels like they can control it. Hey, this is a good feeling, I got this under control, no problem at all. But soon it starts taking over their life. And that's where that transition starts to happen. Something's happening in the brain, which we're going to talk about in a moment. And so those formal pleasurable things that they found great in life, you know what? They're just not as pleasurable as taking the drug. And so the drug starts to become the most important focus in their life. Taking the drug becomes necessary to feel normal. And so they need to keep taking more and more. So they start developing a tolerance. And we're going to talk about how that develops in the brain as well. They compulsively seek and take drugs despite tremendous consequences. So even though they know they're putting themselves in harm's way, they will seek that drug and get it no matter what. It is more important than anything else. So some of the chemistry behind that. So the reward pathway. So here's some basic thoughts about the brain. So the frontal cortex of our brain tells us, you know, it kind of helps us stay away from bad things, right? This is a bad idea, don't do it. You know, don't jump off the bridge, you die. Okay, so your frontal cortex tells you don't do that. The problem is drugs of abuse, they activate the limbic system. It's a very primitive area of our brain, the central part of our brain, the VTA, the nucleus accumbens. This is the focus of the pleasure center. There's dopamine receptors there. Opiates, almost all drugs of abuse create stimulus of the dopamine receptors in that area. And so then when it gets stimulated at a high level, higher than anything else that they've experienced, they have an area of the brain called the prefrontal cortex. And the prefrontal cortex says, wow, we have to remember that because that was awesome, right? So they get this positive reinforcement saying, we have to remember that. And at some point, there's this recircuitry, right? There's this sudden, because, you know, most of the time you'd say, I need to go out here and get this drug, right? And it might be a dangerous situation, and I'm going to put it in a needle and stick it in my arm, and I could get an infection, and I don't know, maybe it's a dirty, I think it's an okay needle. But, you know, who's thinking like, I mean, this is crazy thought. What are you thinking? You're going to put yourself in some dangerous situation. So the frontal cortex helps protect us from that. But the prefrontal cortex is now taking over, saying, yeah, we got to do that no matter what. No matter what the harm might be, we have to get that drug again. And so that's where that recircuitry happens, and we start seeing what we thought was a bad choice, right, before, because from us on the outside, we're like, what are you thinking? And in reality, they're not thinking, right? They're not thinking normally like they used to think anymore. And so now it's not just a behavioral issue, there's actually a brain circuitry problem going on. So virtually all drugs, like we talked about, are dopamine agonists. That means it stimulates those receptors to release dopamine. And you have virtually a flooding of dopamine at the reward center. I mean, it's just an overwhelming amount of dopamine. It's higher than any high they've ever had. Usually, you know, you'll get the euphoria. It gets strongly reinforced, like we talked about with that prefrontal cortex saying we need to do that again. But over time, as they start doing that over and over again, those dopamine receptors either decrease in numbers or they become less effective. So what do you have to do? You got to take more drug, right? So what started as a little bit now starts to become more and more and more to numbers that you guys have seen before where you're like, you got to be kidding me. This would kill me if I took this much drug. But they literally are taking that every day just to get that same stimulus in their brain. And it's not a stimulus of getting euphoric anymore. It's a stimulus of feeling normal, right? Just to function. You have somebody that's addicted on opiates, they're like a slug in bed, right? They take an opiate literally to get energy. I mean, if we're not addicted to opiates here, we take an opiate, we fall asleep, right? We get tired, we're like listless. Completely the opposite with an addict. They take that and they get energy again because it's stimulating those dopamine receptors to get back up to a normal level of function. That kind of helps understand how craving works. So when you get these high highs from these dopamine surges, what typically happens is they go back below baseline. So let's talk about normal function, right? If we do something that stimulates our reward center, we go out, we have a nice meal, we have a stimulus of our dopamine receptors at the nucleus accumbens in the reward center. This is a normal process. It goes up and it comes back down to normal baseline. Intimacy, same thing, goes up, comes back down to baseline. For opiates, what happens is it goes very high. Methamphetamines, very high. But the problem is it goes below baseline again. So when they have this below baseline dopamine level, they are listless, they're functionless. So they have to take an opiate just to get those dopamine stores back up to feel normal again and have normal function of life. Some of the things that are very fascinating, we don't fully understand. We've talked about re-exposure to drug, that prefrontal cortex has that memory of that, wait, we need to repeat that again. So we know that the prefrontal cortex is involved when you re-expose somebody to a drug. Let's say somebody's been abstinent for a long period of time and you think, how could you possibly get back on this again? When there's a re-exposure of the drug, one of the pathways is from this. Sometimes stress, right? Stress causes anxiety and increased stress, where the corticotropin releasing factor is one of the neurotransmitters that's being used there to create a situation where it feels like the patient needs to use again. Sometimes you'll hear people talk about, I used to drive by Kentucky Fried Chicken and I'd suddenly feel like I need to use. Why? Because I always used to score at Kentucky Fried Chicken, so they'd smell chicken, and every time they smelled chicken, that would have that feeling like I need to use again. So some of that isn't even involved with the prefrontal cortex. That's a neurotransmitter. It has to do with the amygdala, a completely different area of the brain. Glutamate happens to be the mechanism in that situation. So these are other areas of the brain that we know are being stimulated from different ways that people are feeling like they need to use again. So we still don't know all the answers to this. But we do know, as a medical profession, that we started to view this a little bit differently, and we started to view this as a medical disorder. Go figure. So we knew that we needed to treat this a little bit differently, not just a behavior, but also as a chronic disease and using medication. So some of the medications, like we'd mentioned before earlier, there's methadone, there's buprenorphine, and there's naltrexone. So what do you want to achieve when you use a medication? Well, obviously once a day dosing would be great. We want to get a patient where they have 24 hours where they're not having any withdrawals, they're not having cravings as well. The dose should be able to reduce or eliminate drug hunger or craving like we talked about, right? So we want to actually boost those dopamine levels up enough where they're feeling normal, where they're functional again, where they can engage in treatment, where they can go get a job or go back to school, whatever the case might be, get their life back together again. It should block the reinforcing effects of opiates. So if I got an opiate that was in my system now, I don't suddenly have that trigger again to go ahead and start going off the chain, off the trail, and go and using again. And then also tolerance to any sedative effects, right? So obviously these are opiates. Can they cause sedation? Yes. Well, we don't want to create sedation. We want to get to a situation where those dopamine levels are normal and there's no sedation, there's no withdrawals, there's no cravings, there's just a feeling of normal, right? And that's how we're trying to use medication in this situation. So let's talk about methadone. Am I doing well on time so far? Methadone is a Schedule II narcotic. It's a mu receptor full agonist. So we talk about mu receptors. This is where the receptors that are creating this problem, we'll just keep it basic. The mu receptors are the receptors of that's creating the dopamine response, and this is the focus that we're trying to treat for this abuse. This is a full agonist. That means it turns the receptor on full blast, right? So it's turning it on all the way. And that'll be important to understand when we talk about buprenorphine, because that's a partial agonist. This has a long half-life, 24 to 36 hours, so that kind of fits the bill, once a day dosing. 80 to 90% bioavailable. That means when they take that medication, most of it actually is going to be used, not urinated out or digested by the liver somehow or lost. It's stored extensively in the liver and it's lipophilic, which gives it some unique properties. So some of the things, I was not on the right slide, sorry. You have to think about it as a methadone induction. There's some training. There is a little bit of an education curve on this, and so you need to understand that when you start to do an induction on methadone, you need to have the training to know how to do this correctly, because it can be a dangerous time. It's the most dangerous time in the first couple of weeks when you're doing an induction. The lipid saturation is about day 4. So in other words, if I gave you a dose, as you can see on this graph here, if I gave you a dose of 30 milligrams a day, on day 1, you're going to be at a certain level. If I use 30 milligrams the next day, same dose, day 2's levels are going to be higher. If I gave you 30 milligrams on day 3, day 3's levels are going to be even higher if I took a blood level in your blood system. So you can see it actually builds up into the stores. You get to that maintenance phase where that's what's called, not maintenance phase, a steady state, where the amount of methadone going in is the same that's being taken out of your body, is about 4 or 5 days. That's what we call the half-life of the methadone. We got to be careful. Obviously, if patients are going to have this at home, and it gets in the hands of children, overdose in children could be devastating, obviously. There's lots of drug-drug interactions with methadone, especially with benzodiazepines. There's also something called the QT prolongation that we're concerned about as well, because there's a lot of other psychotropics that patients take that increase the QT in an EKG. And if you get too wide, you can go into something called VTAC or torsades, and you can die from that. So that's a bad thing. We don't want people dying. One of the thoughts that we usually do with methadone is we start low and go slow, but you got to be careful. You don't want to start too slow and be too low, otherwise people will continue to use while you're trying to get them to a point where they're feeling comfortable again. It needs to be individualized. You can't just say, all right, everybody gets 30, 40, 50, just do your thing. No, you have to individualize your doses. It's about 10 to 30 milligrams is the initial dose. The peak level is about 2 to 4 hours. That's an important thing to understand because we want to know how people feel about 4 hours later. We gave you 100 milligrams at some point. How do you feel 4 hours later? If you're still having withdrawal symptoms, maybe we need to go up. If you're feeling sedated, maybe we need to go down a little bit. Typically, there's 4 to 5 half-lives, like we said, to get to that steady state, and the goal is about 24 hours without craving or withdrawals. So really, this is done in methadone clinics or opioid treatment programs that we've talked about. It's most successful when it's done long-term. It's very structured. These clinics are regulated. I don't know if everybody's been to a methadone clinic before. It's pretty fascinating. I know there's a lot of different thoughts behind it and actually some bad stigma and some wrong stigma actually that are attached to it. The patients must come every day. You need to understand, these are amazing patients because to get 1 day of take-homes, that means they got to come every day. To get 1 day of take-homes, you got to be like perfect for 90 days. 3 months. Could you guys, I mean, you guys can't even take your antibiotics all the way through, can you? I mean, I can't. I mean, that's being at home on your own, having the pill, I can't even do it. But they show up every single day. Their urine drug screens need to be negative for illicit drugs. They need to go to their counseling appointments. They need to go to see the doctor. They need to be perfect almost, which is really hard to imagine just to get 1 day of take home. Yet people are doing that and they're committed to doing that. So hats off to that, it's amazing. They get access to nurses, they get access to doctors. APCs, you know what that is? Advanced Practice Clinicians, yes, nurse practitioners and PAs, that's the new phrase. Psychosocial needs assessments, supportive counseling, family support services, referrals to communities. So really when you go to an OTP, you get comprehensive care, which is fantastic. Does everybody have to be on it forever? No. Some patients might need it long term. There's truly some patients that are going to need it probably the rest of their lives. But we also want to offer the opportunity that if you start to become more stable. So again, what's the concept? We're trying to stabilize somebody, not having withdrawals, not having cravings. But now let's start working on your life again, right? Let's start building the family structure back. Let's have you go back and get an education. Let's see if we can get a stable job. Once that happens, now you can start talking about, hey, what's the next step? Do we stay on this long term? Do we transition to something else? Do we eventually go into an abstinence situation? So maybe we talk about transitioning to buprenorphine or even naltrexone eventually. So let's talk about buprenorphine. So buprenorphine is a partial agonist. We talked about a full agonist, turning that light switch on all the way, right? That receptor goes on all the way. Think of buprenorphine like a light switch monitor, right? You're only turning it on halfway. Even though I'm stimulating that receptor, that mu receptor, I'm only turning it on halfway. So think about this, it's very important. If I'm on methadone, right, and my receptors are fully charged right now, and they're releasing dopamine, and I get put on buprenorphine, right, that means I've just taken my light switch and dropped it down halfway. So I'm immediately going to withdrawals. So you got to be careful when you transition from methadone into buprenorphine, because buprenorphine is a partial agonist. It displaces the methadone, and will actually reset that level to the halfway mark, basically, on the light switch, and so they can have a precipitated withdrawal. But because of that, it's interesting because it adds a little bit of a safety profile, right? So if it's a full agonist, we got to be careful not to give too much because we can overdose. In a partial agonist situation, it's like I can keep giving you more, and I'm only getting your light switch halfway up. I can give you more, and your light switch is only going halfway up. So there's a safety factor that's very hard to overdose on this medication. Can you overdose? Typically, if you have other drugs on board, like benzodiazepines. The half-life's about 37 hours. That fits the bill again, right? Once a day dosing for the most part. Ceiling effect, like we talked about, less overdose. And it can often be combined with naloxone to deter IV use. That's why you'll hear the phrase Suboxone or Bunavail or Subzol. Those are the 3 brand names that are out there right now. They include naloxone in it. What's the point of that? You take it, it dissolves under your tongue, you get the buprenorphine that dissolves, it's introduced into the body, it absorbs very well. Naloxone, it doesn't absorb very well under the tongue. Maybe very little gets absorbed. So they don't go into withdrawals because naloxone is an antidote, right? That is an antagonist. So I literally, if you had an overdose right here on opiates and I gave you naloxone, I displace all of your receptors that have opiates on it. I replace it with naloxone and I turn off your receptor. So you immediately wake up and you breathe again. That's a good thing, right? Naloxone saves lives. So in this situation, you just got to be careful that you wouldn't inject this. Well, we're not giving it that way, right? If it's going under the tongue, it's not absorbed. They're just getting the buprenorphine. If they say, I'm going to go take it, I'm going to melt it down, I'm going to shoot it up, now it's available, right? So that naloxone now is active and it blocks the receptors. So what addict is going to do that? Say, hey, I'm going to go shoot this up and all of a sudden go into withdrawals? Well, none. I mean, nobody's going to do that. So it doesn't make sense. So that's a safety mechanism that they put in there, and that's why naloxone's inside it. Typically, who's your patients for this? These are just generalities. The low to moderate opiate addiction patients need to be in withdrawals. Like I talked about, you could precipitate a withdrawal. If somebody comes in and they're literally just took their heroin, you don't give them buprenorphine right away. They will have they will have a withdrawal at that point. Recommended about 2 to 4 milligrams a day is the dose, but in clinical practice, it's typically a little bit higher with people that know what they're doing with that. You can repeat that, start to increase about 2 to 4 milligrams the same day, about 60 to 90 minutes after their first dose, obviously if they're having withdrawal symptoms. And typically, they're going to get somewhere between 8 and 16 milligrams. The FDA level that they recommend is 24 milligrams. And depending on state law, the take-home requirements are a little bit differently. So the next slide we'll talk about. You can get this medication from doctors that have gone through getting a DATA 2000 waiver. You got to go through 8 or 9 hours of education so you can get a waiver and be able to prescribe that medication. So patients can go to a clinic, they can see you, they can get a prescription, they can go home. Maybe it's a week, 2 weeks, up to a month. And so that gives people flexibility to continue their life. Obviously, if they're homeless, right, and their life is out of control, and they don't have that structure, that might not be the best situation for them. They may want to go into an opiate treatment program. And can you give buprenorphine out there? Yeah. So opiate treatment programs can also give out buprenorphine as well. They could even do naltrexone, but typically they're going to probably stick to the methadone and the buprenorphine. And then the take-home requirements, depending on the state law, are a little bit different. They could have quicker take-home privileges when they're in an OTP when they're taking buprenorphine, so it doesn't have the stringent regulations like methadone does. It's best when it's used in comprehensive care. It can be used in detox. We've just noticed over the times and looking at the outcomes that it's usually not the best results. Typically, if we do it in a comprehensive care and do it over a long period of time, we seem to have the best results. Like any narcotic, it's a narcotic, right? So you can have nausea, vomiting, constipation. You can see some of the side effects, and that's the same with any opiate that's out there. So here's how it comes out. You have sublingual films. Those are like the Suboxone we've talked about. Also the Subzolve comes that way. You have generic pills, the sublingual tablets. They'll dissolve under your tongue as well. There's the buccal mucosa, that's the Bunavail. So it puts it on the side of the cheek and just dissolves. Takes about 10 minutes and goes away. And then they just go about their business. They have implantable devices that are good for about 6 months. There's certain niches where that might be a good situation, maybe in the Department of Justice. And then they just came out in December in injectable form. It's kind of expensive. I think it's $1,500 or so. It's for a month. And it just got approved by the FDA in 2017. So the education's going out for that now, so there hasn't been any studies on that. Finally, I want to talk about naltrexone. Naltrexone is a fascinating drug. It's a pure, long-lasting opioid antagonist. So it doesn't actually make those dopamine levels splurge like they do with the other agonists that we talked about. It actually blocks receptors. So it decreases the amount of dopamine released from the nucleus accumbens when an opioid is given. So if I have naltrexone in my body and I take an opiate, I don't get that reward center rush again, right? So it's like, well, that was kind of pointless. I'm not going to take that drug again. It reduces craving. Well, that's fascinating. Can you imagine if you talk to a lot of addicts, you say, hey, listen, what's one of the biggest problems you have is the craving. I want to keep taking that drug and I just want to keep doing that. If I could get that out of their body, get that out of their mentation of saying I need to have that drug no matter what, that's a huge benefit. And it also works with the alcohol receptor. So now you have opiates and alcohol, so it decreases craving from that standpoint and blocks those receptors. Very few side effects. It's super boring to the addict, so there's no street value, right? You can't get high off this. I could give you, I could just put a box of Vivitrol out there on the street and nobody's stealing it, okay? So it's just gonna sit there. There's no withdrawal when stopping it. You literally could just say, well, I'm not gonna take it anymore, and guess what? Nothing happens. You don't withdraw from that. It comes as tablet form. It's once a day, but we've noticed that, oops, went too fast. The form that we talk about the most is the injectable form. That's Vivitrol, that you'll hear is the brand name. And so that lasts for a month. There's lots of different situations where we can use it, but it really has some great value in criminal justice system. Healthcare professionals, nurses that want to have a NARC key still and be able to work. If they are taking Vivitrol, they can get that access again, and also in aftercare. Patients need to be detoxed off opiates first. It's very important to understand that we're blocking the receptors. So if there's opiates in their system, it will displace them. They will withdraw from that. So you want to make sure that they have completely detoxed off that. So you obviously want to avoid that with people that were on methadone and buprenorphine for at least 2 weeks before you give that injection. It's better outcomes if you're using psychosocial support. And we also need to educate patients that, listen, you don't have any tolerance left. So if you were to go out and use drugs again after you're off the naltrexone, you can overdose. So you need to remember that and be very careful. Which patients are motivated, monitored professionals like we talked about before. You need to be abstinent for 2 weeks from long-term opiates. And also, this is great with patients that have intense alcohol craving. What's the duration of treatment? I really appreciate what was said earlier. This is a decision between the doctor and the patient. You know, putting some type of arbitrary limit in there does not make a lot of sense. But typically, as a rule of thumb, think about it like a year cycle, right? I have to have the Christmases or whatever the anniversary was of my father's death or whatever the bad situation was. If I can go through that drug-free, that's a huge benefit, and this helps in that situation. Conclusion, we discussed the current opioid epidemic, understand how opiates change the way the brain functions, understanding the role of some of the medications that are used. And that's it. No time for questions, because we're moving, but I'm here all day.